Good afternoon, everyone. Welcome to our GCDTR seminar series. It's my absolute pleasure to introduce Dr. Alka Kanaya. Alka Kanaya is a general internist and also an epidemiologist. She is the director of the Clinical Translational Sciences Training Program at the University of California, San Francisco. Her research has a focus on cardiovascular disease and diabetes in South Asians. I'm sure you're all well aware that she is the principal investigator of the MASALA study, which she's going to be talking about today. So I'm not going to get into the details of her scientific accomplishments. We're going to get to see a lot of that here. She's been awarded, however, for these contributions by the American Diabetes Association, the Kelly West Award, which is an award for outstanding contributions to epidemiology and biostatistics in the area of diabetes. What I do want to also flag, though, about Alka's work before she launches into her talk is that in a time when we're talking a lot about diversity and equity, I think the kind of work that she does and my understanding of her life's mission of bringing representation to epidemiology is one way I think that we don't talk about enough in terms of the diversity and equity work we do. So it is not just about increasing diversity and equity in our institutions, but I think also in our science through the work of, say, the MASALA study and other endeavors where we are trying to increase the representativeness of who we're studying. Another thing I just want to point out is that her work does an outstanding job of integrating physiology and biology with social context. Every time I've seen Alka speak, there is sort of new and insightful thought and consideration of social context and environment, which again, sometimes we put ourselves into silos of being all social people or all physiology people or genetics people, but I think bringing it all together is just really remarkable. And the last thing I want to say is Alka brings a lot of humanity into her work. And so I'm very excited to hear what she has to tell us today about MASALA and her other research. Thank you.
Thank you. That was such a nice intro. Thanks, everyone. And really, just an honor to be here again. This is my third trip to Emory, and I hope not my last. I have so many friends and more friends now. So I'm going to leave a lot of time at the end so we can interact and discuss and think about new ways forward, because I wanted to give you a little bit of an overview of what we've learned so far with the MASALA we've been doing. So as you all know, Asian American is a very large umbrella term in the United States, racial term that includes people with origins from 23, even more countries. And it's a very large and growing population in the US. So according to Census 2020 data, Asian Americans grew almost 39% in 10 years, and the most rapid growth is actually in the South Asian American populations. So currently, Asian Indians are the largest subgroup of Asian Americans in the US, and this is when you ask if you're Asian alone. So if you ask about, in combination with other race groups because of intermarriage, then Chinese are still the largest in the US, but alone Asian Indians are. And what we learned from lots of cross-sectional studies from around the world is that when you aggregate Asian American data together, you miss important nuances. And that's been kind of shown here. This is data from Northern California Kaiser, an integrated health system, and they looked at who developed heart disease, heart attack, over a span of about 10 years. And in this column to the far left are South Asians, and you can see that all those bars are higher than every other group here, including East Asians, other Asians, Black, Hispanic, white, multi-ethnic. And that is important because when you aggregate all Asians together, that really does go away because the more numeric groups like East Asians have lower incidence of heart disease. And it's what's important for us to really think about each of these groups separately. We need data and representation from each of these groups to really know what is happening. Here's another very scary new set of data that looks at mortality from ischemic heart disease in the United States. Men on the left, women on the right. And I want to point your attention to that black bar, the black curve on top, which is the non-Hispanic white population. So this is data from 2003 to 2003 to 2017. And you can see the slopes for who's dying of heart disease has gone down nicely for both men and women. It's almost like a full line here if you connect those two. But what I want you to focus in on is the green, line right there, and that's Asian Indian mortality. And that curve is going in the wrong direction for men, and it's about to cross the white men curve, and the women have already crossed the white women. So even though rates of heart disease mortality are dropping in all Asian groups, they're going in the wrong direction for Asian Indians. So what is going on with this, ethnic group that we don't really understand? And this brings us to national data on diabetes. And again, aggregated data for all Asians together here shows that Asians have about 19% prevalence of diabetes compared to other groups. But when we disaggregate the data, and we could only disaggregate based down to the country of origin and in geographic regions because of the small numbers that were oversampled in the NHANES, you can see again, big differences with South Asians having the highest prevalence of diabetes. So this is why, given that we have higher rates of diabetes and heart disease, and now growing rates of mortality from heart disease in the United States, that we really do need to understand better what we can do to curb this cardiometabolic disease epidemic. And so that was really kind of the foundational idea for why we needed South Asian American data for the Mediators of Atherosclerosis in South Asians living in America, MASALA study. So we got a R01 grant in 2010, and this was a below the budget max. So if anyone is writing R01s, you know what that means. It's very little money for doing clinical data collection in human beings. But we were able to secure this grant to sample South Asian Americans between age 40 and 84 without any known cardiovascular disease from two sites, my site, UCSF, and Northwestern University in Chicago. And it was and is still the only longitudinal cohort of US South Asians. And why was it that we excluded people with any known cardiovascular disease? And that's because we wanted to be parallel to another ongoing study in the United States called the MESA study. And that was really just a nice point of leverage, great data set that NHLBI was putting a lot of money into with 4 different groups, white Americans, Black Americans, Hispanic, and Chinese Americans, so we could be a comparison to that ongoing study. And so none of these people in both of these studies had any known cardiovascular disease, so they couldn't have had any procedures on their heart, they couldn't have had atrial fibrillation, stroke. So if anything, if you've made it to age 84 to be in these studies, you know that this is a healthier subgroup of people who even qualify to be in the study. So keep that in the back of your mind, that this is not really, a prevalence study for the United States, because many South Asians wouldn't qualify to be in the study. So what have we accomplished over the last 10, 15 years? I want to shout out to the other PIs of MASALA, Dr. Nami Kandula, who I would love for you to meet and have her come here maybe next year to give a talk. And Nadia Islam is our newest PI who represents the newest wave of recruitment from NYU. So we started the exam 1 was in 2010, and we randomly sampled the areas around San Francisco, Bay Area, and Chicago, and invited in 906 people to be in the study. And then exam 2 was done 5 years later, and then we got some philanthropic funding to actually expand the cohort a little bit with 258 new people. And currently we're in the middle of exam 3. We're actually concluding exam 3 in a couple of months. And that's really focused on heart function and endothelial function. And we are currently recruiting Bangladeshi and Pakistani participants from 2 sites to double the size of our cohort to 2,300. And we hope to release these data later this year. And so there'll be a lot more new ideas for writing papers and future grants. So what I'm going to try to do in the next 30 minutes or so is show you what we've learned from the original cohort of the 1,164 people who've been in MASALA for about 10 years now. So who are these people? Most are immigrants because the age range, right, 40 to 84, most are first generation immigrants to the United States. Only 2% were born in the US, and a majority are from India. And that represents, the immigration flows to the United States and who lives in these two regions where we were able to recruit from. Only 6% were born in Pakistan and about 1 to 2% in the other South Asian countries. And that's why it is so imperative for us to be more representative about the South Asians living in the United States now. And that's why we're oversampling Pakistanis and Bangladeshis. And so we've completed some whole genome sequencing. And with that, we've looked at the genetic ancestry of all of the participants in the study. And what it shows you here is two principal components really help to define the majority of genetic ancestry. And you can see there's one cline here going from north to south, and this is including Pakistan, Bangladesh, and Sri Lanka here. And they're all on one cline, which tells you that genetically, this is a very similar population of people, although geopolitically very different, and behaviors and cultures may be very different, but genetic ancestry-wise, it's actually very similar. There's a cluster here from Gujarat, which I'm not quite understanding what is going on with this special different cluster of people who come a little bit differently, but we can talk more about that. So this is important because we can aggregate in a lot of ways to kind of understand, what may be biologically similar in the groups, but we need to disaggregate when we're talking about social and other, environmental effects. So who's in this study? At least in the first wave of the study, about half men, half women, half were recruited in San Francisco and half in Chicago. And the mean age was about 57. There's a nice normal shape distribution of how long they've lived in the United States. So we have some new immigrants and we have some people who've been in the US for more than 80% of their life, but right in the middle, about half have been in the US for half their lives. And it's a very high socioeconomic group. And again, given the reasons for immigration, given the people who could immigrate after the 1965 Immigration Act, you're all aware of this, that people coming for higher education or with professional degrees have been allowed to immigrate. And this represents really the first waves of immigration in the first part of MASALA, which is actually now looking at the new data coming from our wave B enrollment of Pakistanis and Bangladeshis. The average time in the US for Bangladeshis is 10 years. Average time for Pakistanis is 20 years, and for Indians it's about 30 years. And so that represents, different waves of immigration, and we'll see a lot of more heterogeneity. So here's where we're gonna go. We're gonna talk about diabetes. You're all interested in diabetes. I wanted to spend about half the time on diabetes and body composition. Then I wanted to show you some of the really interesting other findings of atherosclerosis and other related cardiometabolic risk factors, and then spend some time. What have we learned about modifiable risk factors and where to go with interventions? So the prevalence of diabetes is quite high, as expected. So the first bar shows you overall men and women together. In red is diabetes. So 26% have diabetes based on either being on a medication, having known diabetes, having a fasting glucose, 126 or higher, or having a 2-hour glucose tolerance of 200 or higher. And about 1/3, 32% were pre-diabetic, and then the rest were in the normal range. And when you look at differences by gender, this is kind of striking because the men are 30% diabetes prevalence, women 21. So there's, known gender differences around the world, but this is pretty interesting to me. And again, this is not a population-based study, it's more of a community-based study. So could it be that we just did not get the sicker or the women with more diabetes because they just didn't want to be in the study? Possibly. So, and then what we've done is, compare our South Asian cohort to the 4 groups in MESA. I'm using the same color scheme throughout the talk. So South Asians are shown in orange, and then the white for blue for whites, red for Chinese, purple for African Americans, and green for Hispanic. You can see the unadjusted crude diabetes prevalence is very different. And this is not using our OGTT data, because MASA only had fasting glucose and diabetes medication use. When we adjust for everything, including body composition factors, it only made the differences more interesting and more different, with South Asians having a 27%. So you can see that compared to the other ethnic groups that have been known to have high rates of diabetes in the United States, like African Americans and Latinos, South Asians are still 2 to 3 times higher. So why is this? So we looked at the people without diabetes, and we found that HOMA insulin resistance, a surrogate marker of insulin resistance, was higher in the South Asians without diabetes. And this is showing in the left, the orange curve being South Asians, and this is across the age spectrum from 40 to 85. You can see how the higher HOMA IR is there until about 65 years and then kind of drops off. And I think that's because we have sparse numbers also in that 70 to 80 category. And if you look at HOMA beta, a surrogate for beta cell function or insulin deficiency, this is where the South Asians have the lowest HOMA beta cell function all the way through 40 to 80 years old. So these are 2, important reasons that you've all heard of, I'm sure, about, the pathophysiology of type 2 diabetes. And as you know, not much attention has gone towards the beta cell and understanding insulin deficiency. That's, some of the work that Venka is trying to do in advancing this science is really important. And it's the same when we look at HOMA insulin resistance across the BMI spectrum. You can see that even though the BMI is relatively low-ish for South Asians, we didn't have anyone really over 30, and that's why that line plateaus. It's still, the HOMA insulin resistance is higher for the South Asians compared to the other groups, and that's true for waist. And same thing with the beta cell function being low despite having low BMI. So let's see what we can understand about diabetes subtypes. As you all know, diabetes is not one thing, type 2 diabetes. And so Dr. Michael Banks, who's at Wake Forest, took our diabetic participant data and put it together with the MESA diabetes data. And there were about 1,300 participants in both studies together. You can see there's about 217 South Asians represented. And he just used the most available clinical variables, age, BMI, A1C, and came up with 5 different diabetes subtypes that looked at incidence of developing atherosclerosis, so that's CAC, coronary artery atherosclerosis, and also kidney function change over time, over 5 years. And what he found was there's 5 distinct subtypes when you look at MESA and MASALA together. The most common one, with everyone together, was this older age at onset, and that's been seen around the world, right? Everybody knows this. That was very common. The second most common was severe hyperglycemia, which is the insulin deficient subtype. That was the second most common, which is different from what you see in other European populations. It's usually the insulin resistant one, which is the severe obesity, the third most common one. And then insulin use is people who've basically exhausted their pancreas and are using insulin. And then the younger age of onset was very, very minimal. And so we looked at the differences in the distribution of these 5 subtypes by group, and on the far right is the South Asian. And here's what's important, is that older age subtype is not that common in South Asians. It's second common, but the first most common one is that insulin deficient severe hyperglycemia subtype. Almost 38% of the diabetic participants have that. And that's important to compare with the Chinese, right, in the column next to it. Aggregating the Asian data, again, is not doing any service when you see the big differences in the blue there. 67% had older age subtype in the Chinese, and 29, so less than half of the Chinese prevalence, and 22% have the severe hyperglycemia, that insulin deficient subtype in the Chinese. So what did we learn about the longitudinal outcomes for the South Asians for these different subtypes? So the most common one, that insulin deficient one, that one had the highest incidence of developing CAC, coronary atherosclerosis. Now this is important because through, I think, the 1970s, 80s, 90s, all of the studies coming out in South Asians in the UK have always said it's insulin resistance driving atherosclerosis, and that's why there's so much prevalent or incident myocardial infarction or heart attacks. But our data actually shows that it's really this insulin deficient subtype that seems to be most associated with a developing CAC. And that's important clinically because these are the patients that you see in clinic who have this severe hyperglycemia. They should be treated with medications that really help lower risk. And we should be moving away from metformin, sulfonylureas, other agents to the newer agents that have been proven in trials to prevent cardiovascular disease. This older age at onset was the second most common subtype. Again, the most common in most other groups. And that's the least aggressive one. Hardly any bad outcomes. These people, leave them alone. Let them eat what they want. Have them exercise, use less medications, less tight control. These people do not need to be super aggressive about their medications. And then that insulin resistant or severe obesity subtype, they really did not have any major adverse problems, at least in 5 years of follow-up. No higher rates of chronic kidney disease or atherosclerosis. So weight loss, metformin, thiazolidinediones, other agents that help with insulin resistance would be the preferable way to treat people in that. I would also move the GLP-1 agonists into that category, given new data on liver fat. And I jump in, who's here. Yeah, okay. He did a very nice systematic review of all of these data, and on the left are data in Asians, East Asians on top, and the Indians on bottom, and on the right are European other populations. And what I want to point out to you is the severe insulin deficiency phenotype shown in orange was highly prevalent in the Indian data, right? But it's also there in every other type of data from around the world, just not as common. Whereas that insulin resistant subtype was actually more common in the Indian data than what we saw in our MASALA data, that it was slightly more prevalent in some of the Indian studies. But you can see is definitely more prevalent in the European population. And then that older age at onset was the most common one seen in India too, and seen around the world. So we're seeing something slightly different in the South Asian Americans with that older age at onset not being so prominent. And then that last group of that combined insulin resistant and insulin deficiency phenotype, we did not see that in MASALA, and it's possible that we just didn't have enough people to really see that. So it'd be interesting to redo this with the Bangladeshi and Pakistani data together with the Indian data in the US. So moving to body composition, we tried to look at the different BMI recommendations. And as you know, the WHO did recommend using a slightly lower BMI cut points for Asian populations. So we categorized MASALA South Asians with the BMI less than 23 being normal. And that's true for also the same cut point. And on the far left is the people with normal weight or normal BMI. And in the middle is the South Asians, the orange, showing you about a prevalence of 25% had normal BMI. In the middle, overweight is about similar for all 5 of the groups, MESA and MASALA, about 45% prevalence of overweight. And obese, the South Asians are in the middle again with about 30% prevalence of obesity. And why is this important? It's because diabetes screening is not recommended in those people of normal BMI. So less than a BMI of 23, the US Preventative Services Task Force guidelines, the ADA guidelines don't recommend screening in people who have that normal BMI. And that is what Anjali Gujral, who is on Zoom, I think, wanted to look at a little bit more carefully given MASALA and MESA data. And again, this is normal weight, overweight, obese, and the 5 groups that we're comparing. And I want to point your attention to the normal weight group. And what the red dots are showing you are people with 2 or more metabolic abnormalities. This is using the NCEP3 metabolic syndrome criteria. And the red dot shows you that the South Asians have the highest prevalence of metabolic abnormalities, even in normal weight, about 45%. And it's prevalent in all of the groups. So even the whites, there's like 20% metabolic abnormalities in normal weight. The other groups like 30 to 35%. It's just more common in South Asians. And when we model that to say, well, what is a BMI that is roughly equivalent for South Asians compared to whites with a BMI of 25? And this is where, if we look at the orange curve for South Asians, it's about a BMI of 19.6, which is roughly equivalent to a BMI of 25 for whites. And the clinical take home here is that a normal BMI is just not consistent with having low risk for metabolic risk factors. We should either get rid of BMI and not use it in our decision making, and I'm on that, I'm definitely in that camp, or we just need to disregard it for screening. We need to think about risk in a different way, and maybe thinking holistically about a person's family history, a person's genetic ancestry in terms of screening. And I think, I have advocated for us moving more to using fasting glucose rather than A1C. A1C has many limitations, especially in Asian populations. And if we were using the $2 fasting glucose test and having people screen, I think we can do it on a population-based level in everybody. So talking a little bit more about these hidden fat stores. So MASALA and MESA both collected CTs data for getting atherosclerosis of the heart, and we can use some of those CT scans to look at liver fat. We did a separate CT of the mid-abdomen area to measure visceral adipose tissue, and we measured pericardial fat around the heart and also fat in the muscle. And when we compare South Asians in MASALA to the MESA groups, here's where we see real differences in body composition. So the top left is hepatic attenuation. So that's an inverse measure showing how much fat there is in the liver. Lower means more fat, and South Asians in orange have the most significant amount of fatty liver compared to the other groups in MESA. The top right is visceral fat. South Asians had more visceral fat than many of the other groups, although similar to the whites in MESA. Muscle fat on the bottom left. South Asians, again, had higher muscle fat than others, and South Asians had the lowest lean muscle mass. I think this is really important, and another place where we don't have enough data around the world on lean muscle mass, and this is actually a new focus of future MASALA studies, is really to understand muscle quality and muscle function. I think that hand in hand, there's more fat in the wrong places and there's lower lean muscle mass. And Anjali did another paper from MASALA looking at progression of diabetes. And then when I look back at this paper and put it in context with the new paper that just came out from CARS, there's many similarities in what we've been seeing in both of these studies, that people rapidly transition from earlier states of prediabetes to later states of prediabetes. And there's a very rapid transition from the later states of prediabetes to diabetes. And the overall diabetes incidence was quite high. Solid. We're looking forward to redoing these with the third wave of data collection. And when Anjali modeled what are independent risk factors that predict who progresses rapidly through this transition, it was older age, male sex, visceral fat, people with more or higher visceral fat area, and people with more fat in the liver, inverse variable. So these both were independently predictive of who goes on to quickly transition. The more visceral fat you have, the more fat in the liver, the quicker you can transition. And these are most likely people in that insulin resistance phenotype that have this. Another area that we need a little bit more data to know, is it really only the insulin resistant people, or is there a lot of beta cell dysfunction people here as well? So here's a new paper that just came out a few months ago that I want to show you, because I think we have to think about how can we translate some of this into clinical practice or into population health. And we're not going to be doing CT scans on people clinically because it's expensive, radiation, et cetera. But metabolites, so these are things you can measure in blood or urine, and relatively cheaply if you only measure a few of them. So what we did is Megan McAdgill led this analysis where we looked at our CT measures of liver fat and of visceral fat, and looked at the metabolomic signatures from these different fat depots. and put together metabolite scores and then looked at who developed diabetes 5 years later, finding that even after you adjust for all other risk factors for developing diabetes, that these metabolite scores were independently predictive of who develops diabetes and were actually better than the CT scores. So, the CT has some error in measurement, and we're only getting a few areas that we can actually measure these fat depots with. So metabolite scores may be better and maybe something that we can boil down to a nice clinical, pattern where we can say, well, looks like based on your profile that you probably have a lot of fatty liver, and we should be working on, weight loss, maybe using certain agents to get you there, and certain, physical activity and other lifestyle guidance. So I think this is kind of hopefully something that we'll, keep doing in the future. And I'm sure many of you have seen this paper. Venkat and I wrote this opinion piece a while ago, and thinking about why is there so much diabetes in South Asians, putting together the data. And next steps is, we know there's a few things that we believe are evolutionarily determined, like poor beta cell function, as well as low lean muscle mass. I think there is some good anthropologic data showing that this may be something that has evolutionarily been different in South Asians, but both of these things are things that I think we can have a lot of impact with lifestyle changes, and including for beta cell. Definitely there's the whole response to lifestyle here, like ectopic fat and insulin resistance. So this is a working model. We need more data to really confirm some of these assumptions or hypotheses, but would love to keep working to make this clearer. Moving away from diabetes, I want to show you some of the other cardiometabolic risk factors that maybe I haven't shared in the past. When we do regular lipid profiles like you do with your own physician, there's not a whole lot going on here that differentiates the South Asians with the other groups. Some have found that South Asians have higher triglycerides and lower HDL. We didn't see that in MASALA. In fact, other groups have lower HDL compared to South Asians, some Latinos and Chinese, and other groups have higher triglycerides compared to South Asians. So we're not seeing a whole lot of anything interesting here. But when we look at lipoprotein little a, this is where there's a little bit more difference. Again, lipoprotein A is not a test that we normally, do in clinical practice, but now becoming more and more common. This is a genetically determined lipoprotein. And you can see there's big differences with Black Americans having the highest level of 35, South Asians second highest of 17, and the other three groups are fairly low. In some studies, lipoprotein a looks like it's an independent predictor of events. So in MASALA, while we're waiting to accumulate enough events to do that type of modeling, we've started looking at several different surrogate measures. And what we found is very interesting. Lipoprotein a is not associated with atherosclerosis, neither CAC or carotid IMT. It's not associated with aortic valve calcium, as it is in other participants. And we're not seeing the same associations in MASALA. So the question remains to me, is this really going to be that important in terms of risk prognostication in South Asians? Even though levels are high, it doesn't seem to be tracking with many of the other surrogate measures. What we did see is that people who had higher lipoprotein A levels, they had an increase in CAC density over time after 5 years when we repeated their CT scans. And having dense plaques is a good thing. They don't rupture, you have less heart attacks. So higher LP(a) with dense plaques, that's it's just an interesting, provocative finding that we really don't understand and need a little bit more time to put this together. Other biomarkers that people are interested in, so the top two are inflammation markers, CRP, TNF-alpha. South Asians had lower levels than all the other groups in MESA, so not a whole lot of inflammation going on. But if you look at the lower two, adiponectin and resistin, these are hormones secreted by fat cells. And this is big differences, again, because South Asians have more ectopic fat in places it shouldn't be. These are more aberrant in the South Asians compared to all of the four other groups. And that's important to really help to define the South Asian phenotype a little bit more clearly. So what about coronary artery calcium? As you all know, this is a cross-section through the heart, and what we're measuring here is calcified plaque, which is a very early process of atherosclerosis. And as plaque over time becomes vulnerable and ruptures, that's the formation of a blood clot that impedes blood flow, causing a heart attack. So we're looking upstream at calcified plaque on CT scan. And this is what we found in terms of the prevalence for men on the left, women on the right. Look at the differences in the y-axis. We know that men always have more CAC than women. Men had up to 400, women 100. The South Asians are shown in red here. And there's no real difference statistically between the green and the red lines, the green and the white. So men across this age range of 45 to 80 had very similar CAC burden for the whites and the South Asians. The other three groups, African Americans, Chinese, and Latinos, were much lower, especially at the older ages. There's no significant difference for the women, even though it looks like the white women may be higher, but the y-axis is actually very spread out there. So that's important, because going into MASALA, being one of the first studies in the world that had done CAC in South Asians, I really expected CAC burden to be higher for South Asians, given that there's so much more cardiovascular disease. But now this has been replicated 3 times in other, white and South Asian populations around the world, and it's the similar findings have been seen that Europeans and South Asians track very similarly with their CAC burden. But we did look at CAC progression, and that's where South Asian men have faster progression. Here, I want to show you, again, the effect of glycemia on CAC is different. And I showed you that when we talked about the diabetes subtypes, that the people with that insulin deficient subtype had the highest onset of CAC. When we look at glycemic variables like fasting glucose and hemoglobin A1C, the purple bar here represents South Asians. You see a very high slope for the South Asians, meaning that glycemia seems to have more effect on atherosclerosis burden in South Asians than in other groups. So again, going back to why is there so much heart disease in South Asians? Is it because there's so much more burden of hyperglycemia even before diabetes, and we're starting to get CAC and other, atherosclerosis develop very early before diabetes even hits? And this may be what this is pointing to. Finally, I want to end with, modifiable. What can we do? And like as Shivani said, we really tried to spend a lot of time thinking of different levels of data, structural, societal levels, interpersonal levels, individual levels, trying to put this all together. What nodes can we use to really activate and change lifestyle and behaviors in our communities? And I'm going to show you some of the interpersonal and individual level data. So for diet, very difficult to measure diet in any study. We used a frequency questionnaire that was developed in South Asians in Canada in the SHARE study. 164 items, take almost an hour to administer. It was about 40 to 50%, in terms of concordance with 24-hour dietary recall. So none of these are perfect, but it's good enough. And so Meghna Gadgil worked on doing a principal components analysis looking at the major dietary patterns in MASALA, and she found there were 3 main dietary patterns. One was a pattern rich in animal protein. The second one was fried snacks, sweets, and high-fat dairy. If anyone's been to India or any South Asian country or been to an Indian restaurant, you know what I'm talking about here. And then the third is fruits, vegetables, nuts, and legumes. And what's important is the middle and the right pattern are mostly made up of vegetarian or plant-based items, right? So this is important because these were equally prevalent in our population of MASALA. And what do these mean? So just doing a cross-sectional analysis, the people eating the animal protein diet had higher levels of total cholesterol, LDL cholesterol, weight and waist circumference, and higher liver fat, saturated fat. The people eating that middle South Asian, more traditional diet had more insulin resistance, a higher HOMA-IR, lower HDL. The people on the right had less hypertension, less metabolic syndrome. And when Yegna did a metabolite analysis of diets, she found the same exact thing and with different metabolites that clustered with each of these types of diets. So again, I think we're going to be moving away from measuring diet with questionnaires to actually doing metabolomics analysis for diet in the future. Another really interesting study done by our collaborators at the School of Public Health looked at our food frequency questionnaire data and made two diet scores based on plant-based foods. So you don't have to be vegetarian to be included in this analysis. It was basically summing up how many healthy plant-based foods, whole grains, fresh fruits, vegetables, etc., and how many less healthy plant-based foods you were eating. Those are refined grains, fruit juices, starchy vegetables, etc. And what she found is that the people eating the healthy in green had less fatty liver, less obesity and overweight, and less incidence of developing diabetes in fact in 5 years. So, going towards that that dietary pattern that's more plant-based with healthier vegetarian food is really where we need to become. Physical activity data. Unfortunately, even though the South Asians were more educated and higher income than all of the 4 groups in MESA, they had the lowest activity levels. And it was even lower in the South Asians who had diabetes. So a lot of work we can do here. We also found that more minutes of sedentary behavior, just sitting and watching TV, led to incident diabetes separately, independently of other risk factors. What we've also found doing some social networks analysis in MASALA is that different types of interactions really influence physical activity. And in some mixed methods analyses, we found that men who exercise with other men or non-spousal exercise partners had higher minutes of exercise. And for women, it was exercising with her spouse that gave her higher minutes of exercise. And this, I think, the qualitative results of adult children being the most important influencers on their parents' health. This is where I think our interventions are not working as well in South Asians in the US because we're doing one-on-one individual level interventions, and we need to be moving to other models where we bring in the family, especially the adult children and other members of the family to think about family-based interventions. I think one of our most fascinating data is about acculturation. So in the last couple of minutes, we had 9 items where we asked different questions, and then we did another, principal components analysis to come up with acculturation strategies. And what this shows here is that there are 3 main strategies. The far left, the orange semicircle, is the separation class. These are people who are most South Asian or traditional in their cultural values, beliefs, behaviors. The middle group is the integration class. About half of our population fell into that bicultural group, both South Asian and American, and about 30% were in the assimilation, very American in their beliefs and behaviors. And these tracked as we expected with a lot of behaviors. There's more women in the separation class, fewer years in the United States with people who are more new immigrants who are in the separation class, lower socioeconomic status, and less exercise, less tobacco and alcohol use in that group, and more of that South Asian traditional diet, that middle diet that I showed you for dietary pattern. The assimilated group, the more American group, had more years in the US, higher SES, higher exercise, but higher tobacco and alcohol, and more of that animal protein diet. So what does this mean? What does it mean to have these acculturation classes? So what we found in terms of health profiles, looking at these 3 groups, the orange being the most South Asian, is that they actually have the worst of the 3 health profiles. This is cross-sectional data. They have the higher BMI, higher waist, more diabetes, more hypertension, more fatty liver. The people in the assimilation group have the best profile. And this stands in, stands different for other like Japanese immigrants and Latino immigrants from Mexico or other South American countries. The more American your behaviors and lifestyle, the worse your risk factors. So there's something very interesting about the South Asian Americans in MASALA showing that that group may be somewhat healthier. And it could be that, more exercise is part of this, like as I showed you, higher SES. So when we looked at change in risk factors, and these are unpublished data, we looked at, these three groups and what happens to them. And here's a little bit more of a mixed finding where that separation group, the most South Asian group, had the most change in glucose. So worsening of glucose, worsening of CAC, they had more atherosclerosis, but that assimilation group had more weight gain, more waist circumference gain. Again, eating that more animal protein diet, even though they're exercising more, it didn't seem to matter. And so that middle, that integration, the bicultural group seemed to have the best health profile when we look at future change in risk factors. So this is interesting, and I can't wait to actually do another round of this with our third wave in the data collection now. Like I've been saying, Asian Americans are not a monolith. We have to disaggregate data. South Asians are not a monolith. And that's what we've been working so hard to try to get representation in Bangladeshis and Pakistanis. And we've added a new site in New York City to recruit Bangladeshis, Pakistanis, as well as in Chicago. And really can't wait to be able to do a deeper dive into this data. But for now, just showing you some early results from the first 900 or so people we've already recruited. Compared to the Indians in our first wave who were born in India, look at the differences in diabetes between these three South Asian subgroups, with Bangladeshis 51% having type 2 diabetes. That's on the order of Pima Indians in the United States. So that's where I think we're going to have to really understand what is it about social, economic, as well as family and other risk factors that seems to be driving these high rates, because again, the genetic ancestry is the same. There's no biological differences here. There's something else going on that is behavioral, social, that we really need to understand to be able to change trajectories. That's it. I'm going to conclude. We've shown you so far that the South Asian Americans have very high type 2 diabetes prevalence. There's more of this beta cell dysfunction, as well as insulin resistance and ectopic fat. And this low lean muscle mass. I think there's so much more to be done on the muscle front here. This is very rapid transition. We have seen this difference in CAC burden and LP(a), but I think the thing that gives me hope is that there's so many modifiable risk factors. We have to leverage social networks for lifestyle change. Individual level is just not going to do it. And these risk factors vary dramatically for Asian American groups, and we just need longitudinal data and good representation for each group going forward. And I want to show you what we're doing next in MASALA. We're finishing our heart function data, which should be available this summer. We're hoping to get a large grant on cognitive function to really look at cognitive aging. One of our collaborators, Nilay Shah, is working on a second generation MASALA study now, has some good pilot data. We're getting environmental toxins through NIEHS collaboration. Whole genome sequencing just finished. We're hoping to do in top med. And working with you all and all your great data from CARS and kind of put it together to understand the context and how that makes a difference between the US, the UK, and India. And I do want to put in a plug for a brand new Asian American, Native Hawaiian, Pacific Islander cohort that we're launching this fall. And there's 5 sites across the US that are clinical centers, none in the South, unfortunately. Stanford in California, University of Hawaii, and then New York University, Philadelphia, and University of Chicago, and the coordinating centers in Seattle. And I'm privileged to be the steering committee chair for this cohort, and hoping that this will actually shed a lot more information about the differences, the heterogeneity in Asian American, Native Hawaiians, and Pacific Islanders for disease outcomes. So with that, thank you for your attention. I can't take any credit for this without complimenting our whole team. At the top is the UCSF Coordinating Center team and our clinical team. At the bottom is Northwestern on the left, and NYU, our newest team members. And thanks to all of their hard work and the participants that made this